So for endocrine, you have the slides, you have notes, you can put them together. Try not to stress too much about them because you can really go down the rabbit hole with endocrine, and you only need the surface. You're up here, you're not down here. You're up here. Because you can get into lab hell and like all kinds of places that you don't want to go. I don't care what their chloride is or whatever. Nobody cares about that except the nephrologist, maybe, and the endocrinologist. You want to stay at the basics. So you want to look at, for example, the one that I know best because we see it in practice is DI. Okay, so diabetes insipidus. It is not diabetes. I don't know why they call it that. It's so annoying. So we just call it DI, okay? It happens in head injured patients. So and I'm sure it happens in other people, but for our purposes, I want you to put DI with neuro, okay? My example is I had this patient on night shift, and they came back post-crani. So they were 1-to-1 for a little while because they were unstable and had an A-line, ICP, and all that good stuff. So I'm sitting in the room, and I'm watching, and I measured my urine, right? So I tipped the urometer, and that holds 350. And it was real watery, and so I'm thinking, okay, well, maybe they had given mannitol or something before they came out of surgery. So then I sit down, and I'm paper charting because, you know, that's what we did. And I look up and I go, I swear I just dumped that urine. Well, it is like midnight and I'm tired. So, okay, so I'm gonna go dump it again and mark it. And I sit down to chart and I look up and seriously, it is already full. That is DI. It is literally like a waterfall. Like you can't keep up with it. And so I had like a liter out in a matter of half an hour. I mean, it just kept pouring. You dump it and it just keeps coming. Okay, so lots and lots of urine output. Okay? And it looks like, you know, the watery, diuretic looking urine. It's real clear and lots of it. Okay? And then all the things you guys already know, what happens when someone dumps a bunch of urine? They become dehydrated, their electrolytes are following it. So you already know that stuff, right? So if you think about DI goes with a neuro patient, they have a high urine output. And then as far as treatment, well, you got to replace that fluid, right? So we'll replace it usually like 1-to-1. So if they put out 350 this hour, then you put your IV pump at 350 for an hour, right? And then the next hour, they put out 700. So you change your IV pump to 700. And you do that every hour for an hour, I'm measuring how much urine do I have out. And then I'm replacing it with the same amount of IV fluid over the next hour. Then I measure the urine again, and whatever I got, I'm going to replace it over the next hour. Okay? That's just the temporary, we can't do this forever kind of a deal, right? And then you're going to monitor their electrolytes, but that kind of goes without saying. And then there's a drug that we give that literally just stops this whole process. What is it? Desmopressin?
We had patients do that.
Yes, we did. I gave almost everybody neuro patients, and all the responses I got, this patient is just what we heard about in lecture. I know. I just love that. So, and this, or DDAVP, you might also see vasopressin. So they got conked in the head. it broke open the pipe, and now you got to shut the pipe off, or whatever works for you. That's DI.
What is DDABP?
That's what it does with
Oh, okay. That's the.
It stands for something,
something.
but I can't remember what right now. I think pitressin is also another one. Do you see a theme here? Essen? Okay, something like that. So that's a drug that we would give. So I would take these key things, right? Maybe for each one, I'm gonna draw a picture, or I'm gonna use the picture that I have, or I'm gonna find, I don't know, a cute little Foley bag cartoon character or whatever. God, I wish I could draw. There's an artist in here that wants to come out, but, and draw that cute little picture that makes you think of a lot of pee, right? Whatever that is, and put your symptoms next to it, and then put maybe 2 key labs or something, a key treatment, you know, put your drugs in one spot, something like that. That's how I would study it. Or you can do a picture of, you know, Grandma Joe, and I'm gonna put a picture of her on the paper, and she is now gonna have DI. And when you're on the test, you're going, okay, who had DI? And maybe you want to be even more clever. Grandma Diane has DI. Diane, DI, whatever. And I'm going to remember that she can't hold her urine, and she's always like trying to get to the bathroom, and you know, whatever you need to do for a mnemonic, because this stuff will drive you nuts. And the hardest part is we don't see it in the hospital. We very rarely see it. We'll see somebody with a history of hypothyroid or something, but very rarely do we see anything that we can relate to, right? I would focus also, so this goes with the neuro that you're studying. If you had to pick one of the endocrine disorders to know really well, it would be thyroid, because that can kill you. Okay. Thyroid Storm. Everything is up. Thyroid Storm. Blood pressure, heart rate. One more story, and then we'll talk about burns. I worked with this charge nurse, this little Filipino charge nurse, and she was like, she had so much energy, and we worked night shift. And she also was like, she got everybody kind of anxious and stirred up because she was always moving, and we're like, oh my God, it's the middle of the night, you know. And I had a patient that needed to go out, and she goes, okay, Casey, can you transfer your patient out? I've got somebody in the ER that needs to come out. I said, sure. The rule is you have an hour to move your patient out. I said, let me just give these meds and I'll go move them out. So I turned around and I went to go get my meds, and I turned back around and my patient was gone. She had gone and she had ripped the plugs out of the wall and rolled the bed all the way to the other unit. I'm like, what is happening? Where'd my patient go? They're not going to run away. I don't remember what was wrong with them, but they weren't going to run anywhere, you know. And then a couple weeks after that, I just thought she was just energetic. Her eyes got a little bit bulgy, right? And then she was gone for like a month or 2. I said, oh my God, what happened? She said she was hyperthyroid, super skinny, full of energy, running around all over the place. And then she developed her exophthalmos, big bulgy eyes, right? And she said, so what they do for that is they irradiate your thyroid, or they'll take out part of your thyroid. It's kind of like there's not much they can do, right? The thyroid is just going crazy, and we need to put it in its place and say, nope. But then you're always hypothyroid. So now she has to take hypothyroid meds. The reason I tell this story, it's very near and dear to my heart, is that she had these 2 little teacup dogs. And I don't remember what kind, but they were the kind you'd see in the store in the woman's purse, right? And she didn't think anything of it. They put the seeds, the radiation seeds, in her neck, and then she was at home, and they said, stay in your room for like 24 hours or whatever. Her dogs were with her. So after all of this, now her little dogs are hypothyroid. And so she takes her thyroid medicine and she gives them their thyroid medicine, and they're now these little fat sausages walking around because they got irradiated with her when she was getting her thyroid taken care of. I was like, you've got to be kidding me. And then she was upset because she didn't have as much energy. She was gaining weight. Oh yeah, it was not a pretty picture.
What makes hypothyroidism better to have than hyper? Like, why
It's
did
not,
you
it's just that you can treat it very easily with drugs. We have synthetic thyroid.
What's so bad about hyper? Like all those symptoms sounded fine
You
until
can only sustain it.
Fine until our eyes
It's
bulge.
just like, this is why you can't take cocaine for your whole life, because it's gonna beat up your heart, it's gonna mess with your circulatory system. No, so hyperthyroid can develop into a thyroid storm, and all of your metabolism is increased, and your body's gonna wear itself out. So that's why it's bad.
Those people that look like the people that have like Marfan syndrome,
Oh, really tall and skinny?
you get like their eye,
No,
just the
I
eye thing.
I
they
think
were,
that's a
like-
different thing, but the eyes do get really bulgy. I couldn't believe it.
My cousin had that.
You've got somebody now you can have a picture. Look at that. Okay, so that, if you focus on, make sure that you really learn this one well, if nothing else. Okay?